Good evening, everyone present here. I am Faraz from IDCP Group. Welcome all the participants on today's panel discussion on a very important topic on the occasion of World Hemophilia Day. And let me introduce the topic to all the audience who have joined this webinar today. Hemophilia Unplugged, Real Stories, Rare Presentation. There will be having lots of experts as well as we have the case presentation. So before taking this webinar forward, I would like to introduce the moderator for this session. And let me introduce the moderator. He is none other than Dr. Prantar Chakrabarti sir. And let me share some of the achievement of sir. Sir is an ex-professor and HOD of hematology at NRS Medical College, Kolkata, and consultant hematologist Zohar Corporation, Tenkasi. So, by taking not much time, I would like to take Sir on the stage and ask Sir to carry this panel discussion forward and case presentation forward with all your permission, Sir. The stage is yours. You can proceed from
Thank you, Faraz, and hi everyone. So today, 17th April, is celebrated as World Hemophilia Day, and we have been doing it for quite a few years now, and we have a theme every year. So this year, our theme is access for all, and that all includes women and girls, and that's why the theme is women and girls bleed too. The general consensus amongst the medical community is that hemophilia is a disease of the males. So females are carriers. There's a lot of stigmatization attached to that also. But it's a disease of the males, so they only bleed. Now, at the end of this discussion today, you'll realize that hemophilia is a general term, right? That means the disease actually has an affinity for bleeding. The commonest being hemophilia A, which is factor 8 deficiency, hemophilia B, factor 9 deficiency. But you will be amazed to know that there are several bleeding disorders which are even more common than hemophilia. And one of them is von Willebrand disease, which actually has a prevalence much higher than hemophilia, but fortunately, the less severe phenotype is present in most, and it does not have a predilection for males only. It occurs in females. The saddest part of the story is that many females they have bleeding manifestations, but because they are females, their disease goes undiagnosed for quite some time, and that's why they suffer. So today, three institutes have joined hands in commemorating this World Hemophilia Day. We have Postgraduate Institute of Child Health, Noida. We have SET GS Medical College and KEM Hospital, Mumbai. And we have Amrita Institute of Medical Sciences, Kochi. So all these institutes have a program of hematology training, fellowship, DM, and I'm very fortunate to tell you, and it's my privilege that the fellows and the residents there are going to present the cases. So that is how we will do it. The experts are Professor Dr. Chandrakala, who is the Professor, Department of Clinical Hematology at SET GS Medical College and KM Hospital. Two of our residents will present. I'll introduce them shortly. The other next expert is Professor Dr. Neeta Radhakrishnan, who is the additional professor and HOD, Department of Pediatric Hematology, Oncology, PGICH Noida. She is there with her resident, and Professor Dr. Niraj Siddharthan, who is the professor and head of clinical hematology at Amrita Institute of Medical Sciences, Kochi. Our presenters, next slide please, are Dr. Aishwarya Garud, who is a senior DM resident from SET GS Medical College. And then we have the next slide, please, Dr. Rakesh Nair from the same institute, who is also a DM resident there. And then we have Dr. Sudipta Bhattacharya, who would be presenting the case first. He is a fellow resident in pediatric hematology oncology, PGI, who was a past faculty in IQCT Medical College, West Bengal. And last but not the least, Dr. Lindsay Paul, who is a DM resident in clinical hematology at Amrita Institute of Medical Sciences, Kochi. So now it's my privilege to hand it over to Professor Neeta and her team to start the first case presentation, please.
Thank you, sir. At the outset, I would like to thank Dr. Prantha sir and the team at IJCP for this opportunity. I am Dr. Neeta and this is Dr. Sudipto Bhattacharya. So we will be presenting cases of bleeding in girls. Like sir said, it is very apt that we are doing it today. We are doing it on a day when which is celebrated as World Hemophilia Day. And on World Hemophilia Day, the theme this year is, like Sir said, access to all. So this is our institute in Noida. So when we talk about, I'll be giving a small brief about women with bleeding, and then Dr. Sudipto will present cases, and then I'll complete it by a little discussion. So women with inherited bleeding disorders. So whenever, like Sir said just now, we usually think of bleeding as in a bleeding disorder. The term hemophilia comes up, and everybody thinks it's always a disorder of only boys or men. But women too bleed, and that is aptly the term, the theme this year. And which are the diseases where women can bleed? Like Sir said again, it's one of the common conditions is von Willebrand disease, which is the commonest inherited bleeding disorder globally. Then there are some rare bleeding disorders, including inherited platelet disorders, which can also have bleeding. And then finally, women who are carrying the gene for hemophilia A and B, they per se are not termed as hemophilia patients earlier. Now they are also they have also been brought under the gambit of hemophilia, and they are now called women and girls with hemophilia. So these are the groups of people, women who can bleed. And women especially have challenges pertaining to menstrual cycle and reproduction, which makes them more prone for bleeding disorders. This is data from the annual global survey. So there is an organization called World Federation of Hemophilia, which has member organizations from each country called national member organizations, which collate data on the status of people with bleeding disorders globally. So as per their data, there are, you can see, around 390,000, that's 3 lakh patients, 3.9 or roughly 4 lakh patients globally affected with bleeding disorders. In many countries, this is a highly underestimated number because, for example, in India, only around 20% of Indian patients are actually diagnosed. The rest are missed because they don't get to a hospital. And when you talk about women with bleeding, they are more underestimates because very few patients, like even today morning, when a very senior professor in hematology mentioned that von Willebrand disease, probably India is diagnosing 1% of patients who are actually out there. So that's like, this number seems small to you when it is looked at as a global figure, but it's a high underestimation. And one of the reasons for this talk today, and one of the reasons for this theme, is that we diagnose more and more women with bleeding disorders. So over the years, the diagnosis of bleeding disorders in women have gone up. Rare bleeding disorders diagnosis also has gone up, but we are still underestimating diagnosis, especially in women. So globally, of that 4 lakh, just about 1 lakh patients are actually female patients, which could be any of the 4 conditions that I mentioned earlier. So in women, bleeding disorders would be heavy menstrual bleeding or menorrhagia, as we call it. It is a very, very common symptom of bleeding disorder in women. In addition to that, we have conditions called hemorrhagic ovarian cyst. So it is also related to the menstrual cycle, but it is not bleeding at the time of the menstrual cycle. It's bleeding around 10 to 14 days prior to that. So that's called hemorrhagic ovarian cyst. We have cases for that. And then the other types of bleeding that you can see in a woman is during pregnancy, after delivery, miscarriages are more, and then all the other bleedings which can happen in a man or a woman alike, like joint bleeding, deep bleedings into the muscle, as well as intracranial bleeds, etc., can be seen. Now, as far as women are considered, menstrual cycle is a vital sign. So we should know what is normal menstrual cycle for a person. So normal menstruation starts around 11 to 14 years of age. The normal year interval is around 21 to 45 days, and the normal length of a flow is around 7 days. It is usually less, around 5 to 7 days, and not more than 3 to 6 pads or tampons per day. But whenever you have an excess of bleeding, like a person is bleeding every 15 days, or a person is bleeding for 10 to 15 days at a time, or bleeding heavily that you have to change like 5 to 7 pads in a day. So these are all abnormal bleedings and that should be evaluated. So whenever you have a bleeding starting at the onset of menstruation or puberty happened, the girl started having menses, 1 or 2 cycles later onward she started bleeding profusely, so that's a red flag. Menorrhagia, which is refractory to first line treatment, is a red flag. Hemorrhagic ovarian cyst is never normal, it has to be evaluated. Delayed menstrual bleeding is always evaluated. And if you have menstrual bleeding plus gum bleeding, always evaluate. If you have a family history of mother or sisters affected with a similar bleeding tendency, always evaluated. And if you have heavy menstrual bleeding, which is requiring, as in causing anemia and requiring transfusion, that also requires evaluation. So this is the menstrual cycle. You have a ovarian and a uterine phase and a pre-ovulatory and an ovulatory phase. So this is a mid-cycle part which I want to focus, where during ovulation there is release of the corpus luteum, and this corpus luteum, which is a normal phenomenon in all women during the reproductive age group, this happens in every ovulatory cycle. But during this rupture, this can also cause bleeding into the abdomen and cause hemoperitoneum as well. So it can be very, very bad, causing shock also. And this is a very simple score for diagnosing bleeding. And so for whoever is listening in today, there is something called a self bat score also. You can just download it and just quickly see whether you qualify. And if you think your bat score is high, then get to a hospital. And these are the other hashtags which are there around, which is talking about heavy menstrual bleeding in women. And the disorders that we are focusing today is 2 cases of von Willebrand disease, which is a very common bleeding disorder. Although it's very common, you just saw it in the earlier slide that India roughly has around 1,000 women only picked up, 1,000 people only picked up with von Willebrand disease. Around 60% would be women, presumably. And so now I hand it over to Dr. Sudipto to discuss the 2 cases.
Hello, good afternoon, everybody. I'm Dr. Sudipto. I am currently pursuing FNB in pediatric hemato-oncology, first year in PGICH Noida. I would like to discuss 2 cases. This is case number 1. She is a 20-year-old girl and resident of Delhi, and she had first onset of symptoms in May 2015 when she was 9 years of age, when she fell on road and there was bleeding from lips and gums which would not stop spontaneously. Thereby, she was managed with intravenous fluids and fresh frozen plasma and cryoprecipitate in a local hospital and evaluated subsequently for bleeding tendencies. As is also evident from the pedigree chart, that her family history was nil for inherited blood disorders, but her sibling brother, who is 13 years of age, he was also diagnosed with a similar condition. So on the next month, that is on June 2015, she was evaluated with a complete blood count, showed a normal, all 3 cell lines were normal with a prothrombin time of 14 seconds, but an increased PTT of 58 seconds. She was evaluated with factors 8 assay, which came at 2.8% of normal. Since she was a girl, she was evaluated further with platelet aggregation with ADP, ADR, and arachidonic acid, which was normal. Platelet aggregation with ristocetin was done, which was absent, and von Willebrand factor antigen level was measured, which came 1% of normal, indicating a diagnosis of type 3 von Willebrand disease. Then she attained menarche at 13 years of age. That was in February 2019. Initial few cycles were normal. She was not having menorrhagia, probably because they were anovulatory. Then reported menorrhagia. That cycle, the bleeding was severe. It was lasting for more than 10 days, with multiple clots being passed and multiple number of pads being changed per day, with a pictorial bleeding assessment chart score more than 100. CBC was done and that episode, which showed anemia with other cell lines normal, and she was managed with PRBC and tranexamic acid and immunate infusion, thereby discharged on iron oral therapy. So this is the pictorial bleeding assessment calendar chart, which is done in each of month, a daily of the entire cycle. And this pictorially it is represented with number 1 is mild bleeding, which having score of 1, then moderate bleeding with the pads being stained moderately, having score of 5, and if the entire pad is stained, that is having a score of 20. Similar scores are also there used for tampons also. So moving on, so in the next 1.5 years, she was lost to follow up and having repeated episodes of menorrhagia, and PPSC scores were more than 100 in 2 to 3 episodes in per year, with mid-cycle pain abdomen complaint in 5 to 6 episodes per year. Then again reviewed at our center in July 2022 with menorrhagia and severe anemia. She was started on oral contraceptives and discharged. This is the treatment that we offer at our center. We start on progesterone only pills. We continue to give them on 3 weeks with a gap of 1 week, and during that gap we usually give tranexamic acid, and iron supplementation is continued throughout the cycle. She remained well for next 2.5 years. There were no transfusions. Menorrhagia was well controlled. Hemoglobin had improved until December 2024, that is last year, when she had compliance issues with OCP, probably because due to of adverse effects due to OCP. She was admitted with severe pain abdomen during the mid-cycle. On examination, she was having tender abdomen and pallor was present. Ultrasound abdomen showed evidence of hemoperitoneum. She had to be managed with red blood cell transfusions and von Willebrand factor and factor 8 concentrates. She was counseled and restarted on oral contraceptive pills. This is the growth chart of the same patient. So as is evident, at around 7 years of age, she was having growth of parameters, both weight and height, less than fifth centile. Similar kind of trends were followed till 13 years of age. Then there was more faltering of the growth chart until her growth started to pick up when she was started on OCPs and iron therapy and moved to 25th centile at almost 19 years of age. So these are the learning points: that bleeding girls are often overlooked. Cascade screening may fail when index case is diagnosed late. Puberty onset menorrhagia is a presentation in BWD, and bleeding happens both during the menstrual cycle as well as mid-cycle, and mid-cycle bleeds can present with severe anemia and shock. Hormone therapy is beneficial in both, and chronic anemia affects growth. Now, quickly moving on to the case 2. This is a 12-year-old girl with repeated episodes of ecchymosis. She was evaluated at 3 years of age with APTT prolonged and factor 8 at 6%. She had 0% von Willebrand factor antigen, diagnosed as type 3 WD, with younger brother having similar illness. Prepubertal symptoms: she had repeated ecchymosis, joint bleeds, gum bleed. She had 2 massive episodes of GI bleed. First GI bleed in 2020, repeated small episodes of fresh rectal bleed was there, and she received von Willebrand factor and factor 8 locally, and 1 episode of significant bleeding, that is the next episode, which brought to our center. This was the colonoscopy showing diffuse edema and sessile polyps. And 2 weeks later, when she had another massive bleeding, she came with hypotension and 3D pulse with hemoglobin of 4.8, had to be managed with transfusions, factor support, and cryoprecipitate. Repeat colonoscopy showed diffuse mucosal hemorrhage and had to be managed with medically and discharged in a hemodynamically stable condition on iron supplementation. So these are the figures, as is evident, showing diffuse mucosal bleed. Next, post-pubertally, at 2 cycles after Minaki were uneventful, and a third cycle presented with excessive menstrual bleed when she was detected with anemia and supported with factor for 4 days. She was also started on POPs, and iron and tranexamic acid were given, and she had uneventful cycles since then. So these are our learning points: that cascade screening fails when index case is diagnosed late. Puberty onset menorrhagia is a presentation of von Willebrand disease. Diffuse mucosal hemorrhages can be a presentation in GI bleeding and intraperitoneal bleeding in young children. And early intervention, resuscitation, and early factor obviates these symptoms. Thank you.
Thank you, Dr. Sudipto. Now we'll quickly see von Willebrand disease, just basics of how we manage. So von Willebrand factor, as you know, would have 2 major functions in the body. It has a role in platelet plug formation, in platelet function, and then it is a carrier for factor 8. So because if it is not there, factor 8 gets degraded quickly. As a result, it's the value of the circulating factor 8 level also falls down. So that is why you get both types of bleeding. You will see bleeding like mucosal bleeds, like menorrhagia, epistaxis, gum bleeding, etc. And you will also see bleeds like joint, like hemophilia, like joint bleeds, muscle bleeds, etc. You will see. There are three types of von Willebrand disease. Type 1 is around the majority of the patients will fall into type 1, which has a quantitative deficiency. It's not absent, but it is there and it will be less. So this is a normal patient. This is hemophilia and this is von Willebrand disease. I just want to show that normally factor 8 is produced from the liver and it circulates in the body in association with von Willebrand factor, which is intravascularly it circulates as a complex, and von Willebrand factor is produced from the endothelial cell. In hemophilia, the hepatocyte is not able to produce factor 8, whereas in von Willebrand disease, the von Willebrand factor is not produced. Although factor 8 is there, it gets degraded quickly and their levels come down. So this is the basics of the disease. And there are three types of von Willebrand disease. So if it is quantitatively less production, that is type 1. If it is absent production, almost very severe disease, autosomal recessive in most cases, that is type 3. And then there is something called type 2 in between, which is around 20%, which is dysfunctional von Willebrand factor, that it is produced, but it is not functional. So these are three different types of these disorders, and they come to us with especially menarche onset menorrhagia. There would be a history of mucocutaneous bleeding, some family history is usually there. And like I said in the beginning, because this is autosomal dominant, there is a high likelihood that one of the parent would be having it, and they would be having a mild phenotype. They never went to a doctor. So many a times when we diagnose a child, when we ask the mother or father, they said, we also have bruising, but we never went to a doctor for that. So these are the patients we are missing. So if patients are coming to you, especially women with mucocutaneous bleeding, definitely think of this as a condition and evaluate them, especially if they are coming with menorrhagia. So these are the types of mucocutaneous bleeds that you can have. And then, like we said already, these are the other sites of bleeding that they can have. Couple of specific pointers about bleeding. Miscarriages are also common in inherited bleeding disorders, and 20% of women with menorrhagia. So if you can evaluate from a menorrhagia perspective, so if you just look at girls and women with heavy menstrual bleeding, around 20% will have an underlying bleeding disorder. That's usually VWD. On the other hand, up to 80% of women with VWD will have menorrhagia. So that is important. Another specific type of bleeding you would see is GI bleeding, and because of something called angiodysplasia. This is something which is observed in elderly patients with von Willebrand disease. Just mentioning it here because we have had few patients who came with massive GI bleeds in this scenario, but we couldn't find angiodysplasia, but we have reported diffuse mucosal hemorrhage. So you will suspect it, you will get the testing done. There is a lot of overlap between what is normal in von Willebrand factor for a normal human being versus what is type 1. So that there is a strict guideline that is there. I showed the references earlier. We follow the 2021 ASH guidelines for diagnosis of von Willebrand factor. And von Willebrand factor, von Willebrand antigen, that is antigen level. Then you look at an activity level. Then you look at what is called factor 8 also is to be done with it. And some centers also do a platelet function test along with it. What is the treatment? The treatment options are, like in both our patients, we manage the acute bleed episode with von Willebrand containing factor concentrate that is available. In some countries, desmopressin is used widely, and then adjunctive therapy. So many times these adjunctive therapies help us get out of a lot of problems like oral contraceptives, iron, tranexamic acid, etc. You can give von Willebrand factor from either FFP or cryoprecipitate, but that is not preferred because it's not viral inactivated. We generally give plasma derived clotting factor concentrate, which is intermediate purity factor 8, which also has von Willebrand factor along with it. So these are the different products which are available. This is available in our country also through National Health Mission. It has been provided to different states. This is the dosing, again standard, which is all available in textbook, so nothing new here. And in menorrhagia, the two cases that we showed, there is benefit of putting them on hormonal contraceptives, especially progesterone only pills, giving them tranexamic acid liberally because that helps in such patients, and also giving iron throughout the cases. So we'll conclude here by saying that Often diagnosis is delayed. Both these children would have had bruising earlier also, but that was overlooked. So much so that the other child was also born with the same disorder, and then they were got to a diagnosis. And we need to identify von Willebrand disease and heavy menstrual bleeding and anticipate and manage specific bleeding scenarios in these patients. I stop here and we thank you for a patient listening.
Thank you so much, Anita and your team. So we have already have a question in the chat box. This is from Dr. Priyanka Bhateja. She wants to know the mechanism of desmopressin in hemophilia A. And I think the another supplementary question from me is that when you have the nasal sprays and all, we do not sometimes get IV desmopressin. So you might tell the audience about how to use desmopressin, when it works, it doesn't work, and what is the mechanism of action.
So desmopressin, sir, is a good treatment option. In fact, it is given as the only treatment option in mild hemophilia, in von Willebrand disease type 1 patients, as well as in some inherited platelet disorders also. It helps release von Willebrand factor from the Weber pellet bodies. It helps increase the level. Because of that, it factor 8 levels also go up along with it because you have von Willebrand factor. Now, the problem with desmopressin is that desmopressin in our country, like you said, it is available. What is used abroad is injectable preparations, subcutaneous preparations mainly, and there is also a intranasal spray which one puff delivers around 150 micrograms. Whereas in India, what we have is the one which is marketed for nocturnal enuresis, and that is a smaller concentration. It's around 10 micrograms. So because of that, if we were to give it in the doses that is recommended, around 100 mics per puff recommendation, then we need to give multiple doses of it. And the side effect of that multiple doses hyponatremia, because of which we are not able to use it. So in India, we are not using the nasal spray at all. The other preparations can be tried. If you have access to it, you can try it and see. Now, the other issue with desmopressin is two more issues. One is that all people may not respond. So you will have to try. You cannot use it as a single agent, like especially if you're taking up for a elective procedure like dental extraction or something. You cannot use it unless you try and test it earlier, document the response, and then use it later. So that is one. And second is many a times patients lose response as they use. So that phenomenon happens like multiple doses happen if you give, then you lose the response. The body does not respond to desmopressin at all. So that also is an issue. So you can't reliably use it unless you have pre-tested it, you have documented all that pharmacokinetics levels, you have documented, sampled the patient multiple times and done it. So that is the issue why we are not using it commonly.
Yeah. And I think we use tranexamic acid a lot and it actually helps. So that is one thing which is available and we can go. So thank you once again. I go to the next team of Professor Chandrakala and her residents from St. GS Medical College and KEM Hospital. So over to you, Chandrakala, for the case presentations. You're muted.
Thank you, Prantha.
Yeah.
We have two residents, Dr. Aishwarya and Dr. Rakesh, and both of them are in third year DM, and both of them will present. One is a case of von Willebrand disease, how we manage through peripartum. She presented to us like 5 months of gestation, and other one is a carrier of hemophilia and how we manage the surgery. Like who carrier can also have a bleeding. Now this year theme of WFH is women and girls bleed too. So this is a very good meeting you are in, that women and girls bleed too, and then creating awareness, very very important. So I'll hand over to Aishwarya. We'll share our slides.
And for participants who are listening to us, we would like to tell you that you can ask questions in the question box. And at the end, you will also get an e-certificate to prove your attendance here. So be attentive, ask questions.
Okay, can you see our slides?
They haven't come yet. So you have to click present and share the entire screen.
This is yours, no? Yeah.
Yeah, it will be coming. Yes, it's coming.
Uh,
Hello everyone, I am Dr. Aishwarya Garud, SR in the Department of Clinical Hematology in SAIT GS Medical College and KEM Hospital, Mumbai. I would be presenting the case of 31-year-old female with
Can you go
uh,
into presentation mode, please, Aishwarya? That would be better.
uh,
Yeah. It is showing as a slide set mode. So just click on the PowerPoint. Yeah.
presentation slide
Yeah.
show.
Yeah. Slideshow. Slideshow. Yeah. Yeah. Right. Yeah. Yeah. That was the key. Yeah. That is the icon. Click on it.
Hmm.
Yeah.
No, it can't.
It's not going okay. Then you can continue slide by slide. No problem. Will not waste time. You
Yeah.
just change the slides and we will see it. Yeah.
So this huh? Slide over. Uh-huh. It's not moving. Yeah. It is not moving.
It's not moving. I think you have shared the window instead of the entire screen. Can you
Uh,
just stop and again go back and share the entire screen? This happens. This happens in Zoom, in Google Meet, and as well as we are using StreamYard.
okay.
So just share the entire screen.
Uh, then-
And as they're going about it, Professor Nita, if you're there, I have a question for you once again. How do you manage loss to follow up? How do you maintain the compliance? Yeah. Yes. Perfect. Okay. Go on, Aishwarya. Yeah.
Uh, this 31-year-old female presented to us with history of easy bruising on trivial trauma since childhood. She also had history of menorrhagia since puberty, which resolved with taking tranexamic acid tablets. Now she presented to us with amenorrhea for about 2 months. There was no history of any blood transfusion in the past, no history of bleeding disorder in family. She was never been investigated for menorrhagia or easy bruisability. On examination at presentation, her pulse was 94 per minute, BP was 120 by 70 millimeters of mercury. She was having a pallor. Other rest of the clinical examination was normal. Her USG was done for 2 months amenorrhea. As her UPT came positive, her USG obstetric was done, which was suggestive of 10 into 4 millimeters subchorionic collection along the lower pole of gestational sac, which was suggestive of hematoma. Investigations were as follows: HB was 10.4, total counts were 4,500, platelets were 2.4 lakhs, polymorph 72%, lymphocyte 27%. Her coagulation studies were as follows: PT of with a control of 13.5, test reports were 13.9 seconds, APTT was 50 seconds, and mixing studies with normal pooled plasma was 32.2 seconds. Her coagulation profile report is as presented before you. Her factor 8 levels were less than 1%, and von Willebrand factor antigen level was 5.5%. So she was a newly diagnosed type 3 von Willebrand disease, 8-week ANC with subchorionic hematoma. Patient lost to follow up at that time, and then next she presented to us at 5 months of gestation. She was given prophylaxis with immunate 20 international unit per kg, immunate twice a week until delivery since 5 months of gestation. She was again admitted at 39 weeks of gestation for safe confinement. She underwent full term normal delivery. Episiotomy was required for her, and given 40 international unit per kg unit started from just prior to delivery until 3 days post delivery. There was no postpartum hemorrhage post delivery for this patient. So, von Willebrand disease and pregnancy. Women with von Willebrand disease should undergo thorough evaluation for the type of von Willebrand disease and response to desmopressin if the patient has type 1 von Willebrand disease prior to planning her pregnancy. Women with von Willebrand disease who have von Willebrand factor and factor 8 basal levels more than 30 international unit per deciliter typically normalize these levels at the end of pregnancy, and specific anti-hemorrhagic prophylaxis is rarely required in such patients. On the contrary, those with a basal levels of less than 20 units per deciliter usually show an lesser increase, and specific treatment is usually required in these patients. Peripartum. In a case control study, women with von Willebrand disease were 10 times more likely to experience antepartum hemorrhage. In another case control study, there was no increased risk of placental abruption, preterm delivery, fetal growth restriction, or stillbirth that was observed in von Willebrand disease patients. The frequency of PPH in von Willebrand disease is uh, higher as compared to the percentage of all normal deliveries uh, that happen. Then von Willebrand factor and factor 8 increase during pregnancy in normal women. Greatest levels are achieved in the third trimester, levels of about 100 units per deciliter by the time of parturition. Women with type 3 von Willebrand disease typically do not show an increase in factor 8 or von Willebrand factor during pregnancy because their endothelial von Willebrand factor stores are lacking. Thus, von Willebrand factor and factor 8 concentrates may be required during pregnancy to control intermittent vaginal bleed and at the time of delivery for or if the patient is requiring cesarean section. Caesarean section is reserved only for obstetric indications in pregnancies with von Willebrand disease. Replacement therapy is as suggested above, but it is continued for a prolonged period, that is 5 to 7 days, to maintain a factor 8 levels of more than 50 units per deciliter. Factor 8 and von Willebrand factor fall to baseline after delivery, and thus oral fibrinolytic agents like tranexamic acid can be given so as to prevent delayed postpartum hemorrhage due to heavy leukemia. Tranexamic acid decreases the risk of delayed PPH and it is safe during lactation. Significant delayed bleeding may occur in severe cases treated for a short period and requiring treatment with desmopressin or factor 8 von Willebrand factor concentrates. Thank you.
Thank you, Aishwarya. There's one question. The von Willebrand factor antigen level was more than 5%, right?
Yes, sir.
Okay, but the factor 8 was less than
Factor
1%.
it was less than 1%.
Okay,
Yeah, we usually don't see factor eight so low in VWD patients, severe VWD. We were also very surprised. And we also have one more pregnant lady now. She is actually delivered. She also has factor eight level less than 1%. So normally we see at least 3 to 5% in severe VWD patients, also type 3, but this patient had less than 1%.
right. So you can
And then
proceed to
one
the
more
next.
thing, Pranthar, I
Yeah,
wanted to tell is
tell.
in a
Yeah,
patient of one disease, during the pregnancy, prior to the pregnancy or antepartum, we usually don't give any prophylaxis because their levels are at least 3 to 5% factor 8. In this patient, we have given prophylaxis because he had a subchorionic hematoma and the hematoma was increasing in size. So that's the reason. Otherwise, there is no standard recommendation to give prophylaxis prior to the actually for this patient. During the pregnancy, there is no need for giving prophylaxis.
yeah. No, are there any guidelines that their ultrasound monitoring also should be frequent in such ladies?
There is no guidelines. There is no guidelines
Okay.
in this
But
patient.
if
Unless
there
the
is
patient
pain or
goes
anything, maybe the obstetrician, I think the high index of suspicion is has to be there that this is a valuable pregnancy and we have to monitor it like that.
Yeah, as an obstetric ultrasound, we do it actually. For a VW point of view, they don't do that on monitoring in these patients.
Right.
Yeah. So our resident, Dr. Rakesh, will present a case now. Third case, he is going to present a case of hemophilia carrier and requiring a surgery.
Okay. Welcome, Dr. Nair. You can share. Please share the entire screen.
Good evening, everyone. I'll be presenting a case of a 39-year-old female. She is from Parbhani, Maharashtra. She actually had history of easy brewing as on minor trauma in the past, which used to resolve spontaneously. And she had complaints of menorrhagia for the last 2 years before presenting to us and requiring 1 units of PRBC secondary to anemia due to menorrhagia. Along with that, she was being evaluated for primary infertility for the past 1 year. On evaluation, she was found to have uterine fibroid. Hence, as per obstetrician's discretion, she was planned for myomectomy. This patient was referred to us in view of a prolonged APTT value, along with a family history of hemophilia B. So, her family history, we can see that she was the patient's younger brother was a hemophilia B severe type, less than 1%, and she also had a nephew who was hemophilia B severe type, and both of them were on demand factor correction for joint bleed only. Examination was essentially normal. She didn't have any external bleeding manifestation at the time of presentation. Her CBC revealed anemia, HB was 7.4. Other investigations were normal. USG abdomen and pelvis was done, which showed uterus was having an 8 cross 10 centimeter intramural fibroid in the anterior wall of the uterus. Her serology markers were negative. And we did coagulation studies. We can see that her PT was normal and APTT was just delayed by only 5 seconds, and mixing was normal. Thrombin time was normal, but since she was having a family history, we did her factor assay. Factor 9 levels were 29.6 and factor 8 levels were 250 percentage. So since she wanted to conceive and she was planned for myomectomy, so patient underwent open abdominal myomectomy under general anesthesia. On the day of surgery, we gave her 60% factor correction prior to the surgery, and 30% correction was given 12 hours post procedure. And blood loss during the surgery was 250 ml, which was within the expected range. And from post-operative day 1 to day 3, we gave her 40% correction once a day. And from post-operative day 4 to day 6, we gave 20% correction once a day. Post-operatively, she didn't have any major complications, and she was discharged on post-operative day 7. Uh, so my discussion was whether this hemophilia B carrier patients can have low factor levels, and definition of carrier with hemophilia. So I went through the literature. So ISTH has distinguished 5 clinically relevant hemophilic categories. So hemophilia carrier with low levels, that is 5% to 40 percentage of factor levels of 8 or 9, with moderate hemophilia carrier with moderate factor level, that was 1 to 5 percentage, and with severely low factor level, that was less than 1 percentage. And for hemophilia carrier with a symptomatic bleeding phenotype, their factor levels will be usually more than 40 percentage. And there may be a hemophilia carrier with an asymptomatic bleeding phenotype who will be having no bleeding manifestation, and factor levels will be more than 40%, but less than 60% as normal. Since carriers have a wide range of clotting factors, it may be from a very low resembling males as of severe hemophilia, and it may be up to the upper limit of normal. This range has been attributed to the phenomenon of lionization, which is a random X chromosome inactivation which happens early in the embryonic life of individual. So lionization or X chromosome inactivation takes place early in the phase of embryonic development. In some females, the majority of the healthy X chromosomes may be inactivated, uh, and these patients will be having a mosaicism. So they'll be having normal X chromosomes as well as an affected X chromosome being expressed. So there are definitions for obligatory carriers. Obligatory carriers are all daughters of a hemophilia patient, that's a male patient, or mothers of a son with hemophilia with at least one of the family members having hemophilia, or mothers of son with hemophilia and a family member who is a carrier of hemophilia gene, or mothers of two or more sons with hemophilia. This is the definition for obligatory carriers. And for possible carriers, all daughters of a carrier, hemophilia carrier, and mother of a son with hemophilia who doesn't have any family members who either have or are having carriers of hemophilia, and sisters, mothers, maternal grandmothers, aunts, nieces, and female cousins of carriers. These are all possible carriers during the time of conception. So going through a literature, as I earlier mentioned that these patients can have factor levels ranging from less than 1% to near normal percentage, but they will not. But when compared with a non-carrier population, we can see the factor levels will be slightly lower in the case of a carrier female. And in this study, hemophilia carriers as well as non-carrier patients, around 540 patients were taken, and they were given questionnaire regarding their bleeding history and surgical history and obstetric history. So spontaneous bleeding was seen more in the carriers as when compared with non-carriers. We can see the relative risk is nearly more than 1%. That is significant. And those patients with patients having decreased clotting factor levels, and those patients requiring major surgeries like tonsillectomy or tooth extraction, joint bleeds, we can still see that significant bleeding has been noted in those patients who are having a lower factor levels when compared with a carrier with a higher factor levels. And patients with menstrual patients who are in menstrual period, those patients who required who had excessive blood loss, anemia, iron supplementation, or those who required hysterectomy for heavy menstrual bleeding, all of them have we can see that those patients who are having a lower factor, those carrier patients who are having a lower factor level, they had a significant increase in all these events. So concluding, a higher risk of bleeding in carriers of hemophilia was related to clotting factor levels, especially at the time of medical interventions. And this emphasizes the importance of measurement of clotting factor levels in a carrier or a potential carriers of hemophilia. So coming on to the WFH guidelines, so for menorrhagia, delivery, postpartum, surgery, here they have mentioned to keep a target of up to 80 to 100% in patients with hemophilia carriers who are having a lower factor levels during the time of major procedures and even delivery. So recommendations are all known and possible carriers of hemophilia A and B should have their factor 8 or 9 levels measured. And then all carriers who are having a pre-existing factor 8 level less than 50% should have their factor levels measured during the third trimester of pregnancy, and they should be treated to raise the factor 8 levels up to 100% during the time of delivery. And carriers of decreased factor 8 or 9 levels should be treated as mild hemophilia. And when a carrier has a factor 8 or 9 levels less than 60%, clotting factor correction is indicated after trauma, during childbirth, or in the presence of bleeding, on or when planned for a surgery or a medical intervention. And carriers of hemophilia with low clotting factor level should be followed regularly at a hemophilia treatment center. This is as per recommendation of WFH guidelines. Thank you.
Thank you so much, Rakesh.
Yes.
So, Dr. Chandrakala, you want to make certain comments regarding these cases before we proceed to the next one?
Yeah, these two cases are very important in a day-to-day management of hemophilia patients, especially the carrier one. Many of the hemophilia patients' mother have menorrhagia, and they have anemia, but they don't come up to us actually. They don't come because of lack of awareness among the patients and even the physicians who treat the hemophilia patients. So I think it's more recognition of the bleeding disorders and creating awareness among the hemophilia community that even the sisters and the mothers can have, and we can prevent that. At least the PPH can be prevented and the surgery complications can be prevented. So that is the reason the two cases shows that management of peripartum or surgery in carrier patients.
Right. I think, and Dr. Nita's team also highlighted the use of tranexamic acid. This is one drug which I think is not used optimally, but the most important thing is the eyes cannot see what the mind does not know. So, apt to the theme of this World Hemophilia Day, we have to realize that when women are bleeding, it's not about men only having hemophilia. And as rightly pointed out, that some carriers may behave as patients, because for MCQs we only used to learn about lionization, but that is rare. What is more common is that the variability and the bleeding phenotype. So obviously the bleeding phenotype matters, and the clinical acumen should be there to keep our eyes and ears open. We are told not to ask specific questions, but in India, especially to women, you have to ask specific questions regarding their periods and bleeding, so that we can manage them. And if we do not do that, what happens, we'll see another case which will be presented by Professor Neeraj and his team, that's Dr. Lindsay. So now I hand it over to Professor Neeraj for the next case presentation.
Thank you, Dr. Pranthar. Uh, uh, Thanks for this opportunity. And on this World Hemophilia Day, where the theme is Women and Girls to Bleed Too. I mean, we, we have selected to present the story of a woman who had bleeding, and it took some effort for us to control that. So I would hand over to Dr. Lindsay and Dr. Rama to take it from there. Thank you.
Thank you. Yeah.
Good evening, sir. Am I audible?
Yes, you are.
Slides are also visible.
No, slide has not been visible till now. Yeah. From the panel below, present, and then entire screen. Share screen. Yeah.
Sir, is
So
it visible now?
it hasn't come yet. So you have in the bottom panel something called present. When you go to it, it shows slides and PDFs, video file, image file, and share screen.
Yes.
Click on the share screen and then choose the entire screen. Click on it and share. Meanwhile, as a backup, you can just email me the slides, otherwise, I'll present. No problem. Yeah. Don't worry about the technical glitches, they all happen. Yeah, maybe because of the system, it's not happening. My email is prantar@gmail.com. You can just email it to me. And you can introduce. Meanwhile, I'll just share it.
PRANTHAR.
Yeah, PRANTAR.
TAR. Okay.
TAR@gmail.com.
At
Yeah,
Gmail. Okay.
yeah, yeah. You just send it and you can start speaking. Meanwhile, I'll start sharing. Not an issue at all.
Hi everyone. But what issue, ma'am, you are facing, ma'am? Like while sharing, like you have done just few minutes ago, you it was able to see
Yeah.
this.
When we try it now,
Hmm.
when this what is it?
You click below, ma'am. Below there is option of present. Are you able to see that present
No
option
problem.
below?
Okay. So
Yeah.
we are able to see this present screen.
And then
We
you go to
opened.
last option, share screen.
We tried to do the share screen,
Yes.
and when we did the
Then you
share
click on
screen,
entire screen option is there. Chrome tab, Windows, entire screen.
Prantar sir, I have mailed it to you.
Yeah, yeah, I've got it. I've got it.
Yeah.
I'm just sharing it. Within another 30 seconds, I've
Okay, sir.
received.
You can. Meanwhile, you can
Yeah,
share
yeah,
it.
I'm sharing
Thank
it.
you, sir.
So share screen, entire screen. I think you can see it now.
Yes.
Yes?
Yes. Yes.
yes.
Yeah, yeah, that's it. Come on. Yes. Over to you, Lindsay.
Good evening to all. I'm
Yeah.
Dr. Lindsay Paul from Amrita Institute of Medical Science, Kochi. Here I am presenting about a patient who is a 44-year-old multiparous lady presented with heavy menstrual bleed. She has history of menorrhagia since menarche, and she has a history of passage of clothes. She used to change 7 pads per day, and her PBAC score was 241. ICTH BAT score was 6. And the further evaluation showed myoma and adenomyosis with endometrial thickness 5.1 millimeter. And this is how we calculate the ISTH BAT score according to the severity of bleeding from various sites like epistaxis, oral cavity, muscle hematoma, menorrhagia, GI bleeding, like that. Um, this is how we calculate the PBAC scoring. With the scoring, we ask the patient uh, how much the pads will be stained. If the pad is stained very lightly, like this, that will be scoring 1. And if this is the pad is staining like this, moderately stained, it will be giving points of 5. And if the pad is saturated with blood, then it will be giving 20 points, and extra 1 point for small clothes and extra 5 points for large clothes for each pads. And the medical management she received was Trapic MF, Novolon, which was combined OCP, Primiluten, Registron, Marina IUD, Progenova. And due to this failed medical management, we advised for uterine artery embolization, but the patient was not keen. So she underwent total laparoscopic hysterectomy with bilateral salpingo-oophorectomy. And coming to her past history, she is para 2, living 2 with no abortions. history of heavy menstrual bleed, which was not reported because of unawareness. As per the history, she used to change 5 pads per day with passage of large clothes, history of gum bleeding and easy bruisability. No history of any bleeding disorders or menorrhagia in the family. Her first delivery was in 2001, which was a normal vaginal delivery. And there was no increased PV bleeding during the delivery of baby or placenta. After the removal of placenta, she developed increased bleed, which was initially thought of retained fetal products. Hence, DNC was done twice, but she continued to bleed. So, due to continuous bleeding, general medicine consultation was given, and she was advised to transfuse cryoprecipitate, after which her bleeding stopped, and she was supported with more than 10 units of PRBC during that hospital stay, as per the history. At that time, she was admitted in the medical college for about 1 month, and she was further evaluated in a higher center and diagnosed with von Willebrand disease 1 month after delivery. So, further evaluation was done in CMC Vellore and diagnosed with von Willebrand disease type 3. And coming to the presentation, during this total laparoscopic salpingophorectomy with hysterectomy, uh, the we evaluated her pre-operatively with von Willebrand level, which was 1%, and factor 8 level was 3%. So pre-operatively, we loaded her with 50 international units per kg von Willebrand rich factor 8 concentrate, that was immunate, and pre-operatively to achieve 100% of factor 8 level, and proceeded with surgery. And perioperatively, she was managed with immunate. And the vaginal vault was loosely sutured to allow draining of blood, which may get collected in the abdomen. Then factor 8 levels was monitored 12th hourly on the day and next day of surgery to keep levels between 80 to 100%. The CFC was administered to target factor 8 levels as follows, like from day 1 to 3, 80 to 100%, from days 4 to 6 of post-op, 40 to 80% to achieve, and days 7 to 9, 30 to 60, and from days 10 to 12, 20 to 40% of the factor 8. She was discharged on 12th post-op day and discharged with von Willebrand rich factor 8 concentrate twice weekly dosage as prophylaxis. Then on the next day, she presented to ER with bleeding PV. So at the time, due to this bleeding PV, she was supported with von Willebrand rich factor 8, immunate 500 international unit, to aim factor 8 levels more than 100% and von Willebrand factor antigen more than 40%. At the time of reporting to ER, HB dropped to 3 gram percentage, and PRBC transfusion and vaginal packing done. She was observed in labor room. After removal of vaginal packing, since there was no bleed, she was shifted out with von Willebrand rich factor concentrate support every 24 hours.
Yeah, we lost your voice in the middle. So there was no bleed, shifted out with 1 milligram factor concentrate every 24 hours.
Yes.
Yeah.
And she again developed bleeding PV along with passage of clothes 1 week after removal of vaginal pack. And re-exploration was done with immunate support targeting factor 8 between 80 to 100% for the first 2 days, and then more than 50% till 7th day. During exploration, resuturing was done over the vaginal vault, which was loosely sutured after the surgery. Bleeding stopped with resuturing of vaginal vault. And the difficulties faced by this patient were delay in diagnosis, heavy menstrual bleeding, and bleeding after surgery. And this is how we diagnose a patient with von Willebrand disease. If a patient is having bleeding symptoms or family history of von Willebrand disease, the patient should be evaluated initially with the bleeding score, like PBAC or ISTH bat score. If it is abnormal, the patient should be evaluated with von Willebrand factor antigen levels. If it is less than 40%, the diagnosis of von Willebrand disease is likely. So we should perform a RIPA test, desmopressin infusion test, and the family evaluation should be done. And if the patient is responding with desmopressin, the for a minor surgery or bleeding, we can use the desmopressin. And for major surgery, even if the patient is responding to desmopressin, we have to support with factor and von Willebrand factor antigen concentrates. If the patient is not responding to desmopressin, definitely we have to go for concentrates for as a standard treatment or prophylaxis. The medical management for heavy menstrual bleed, we starts with tranexamic acid at a dose of 1000 mg thrice daily during menstrual period, that is about 5 to 7 days, and combined oral contraceptive containing both progesterone and estrogen. And if the oral contraceptives are ineffective or not preferred, IUD with levonorgestrel containing IUD, that is Mirena, is an alternative. This is about the various medical management and including the surgical also for heavy menstrual bleeding in patients with von Willebrand disease. According to this, the patient's outcome is more satisfactory with Mirena, that is levonorgestrel IUD, and also combined contraceptive pills and desmopressin and tranexamic acid also. In terms of improved ferritin level, improvement in anemia and bleeding. But there are some complications with long-term hormonal therapy, like increased risk of venous thromboembolism, increased risk of breast cancer, and injury to those with acute liver disease. These are the long-term complications. And about the factor prophylaxis recommendations for patients with heavy menstrual bleeding in von Willebrand disease, we should give targeted prophylaxis during menses. That is von Willebrand factor concentrate 30 to 50 international unit per kg to maintain more than 50% levels during heavy bleeding once daily for 2 to 3 days, starting from the day 1 of menstruation. And continuous prophylaxis is indicated in patients with severe disease and multiple bleeding symptoms other than heavy menstrual bleeding. The dosage will be starting with 20 international unit per kg twice weekly and optimized according to bleeding. And in patients with von Willebrand type 1, prophylaxis can be given with desmopressin and starting at a dose of 0.3 mcg per kg IV infusion. And if they are not responding, we can give exogenous replacement with factor derived von Willebrand factor antigen and factor 8 containing products or plasma derived recombinant von Willebrand factor concentrates devoid of factor 8, and also in major surgery or major bleeding. The plasma-derived von Willebrand factor 8 concentrates available are alphanate, immunate, and hemate P with the concentration of factor 8 and von Willebrand factor. And next is how to calculate the replacement dose for plasma-derived factor 8 von Willebrand factor complex. The replacement dose should be body weight in kilogram into desired factor 8 rise into 0.5. As the half-life of von Willebrand factor is 12 to 24 hours, frequency will be once daily. And factor 8 levels should be monitored to prevent overshooting of factor 8 level beyond 200%. With this dosage, I have written a example. For a patient with weighing about 60 kg with 1 milligram factor level 1% and factor 8 3%, the replacement dose will be 60 is the weight, 60 into desired factor 8 rise will be 97 to achieve 100 and into zero. 0.5. So it will be 2009-10. We can give according to the nearest close vial, that is 3000 international unit. And these are the dosages recommended for factor 8 in factor 8 millibrand disease concentrates in patients who are not responsive to desmopressin. For major surgery, we should the number of infusion will be once a day or every other day. We have to maintain the factor 8 level between 80 to 100 international unit per deciliter for the first 2 days, and then more than 50 for the next 5 to 7 days. And the dosage will be 50 units per kg. For the minor surgery, it will be 30 units per kg, and we should keep the levels more than 30 international unit for at least 5 to 7 days. For dental extractions and spontaneous or post-traumatic bleeding, 20 to 40 is the dosage. 20 to 40 units per kg is the dosage. And it will be giving as a single infusion. In both these, factor 8 level should be more than 30 to 50 international unit per deciliter, and subsequent infusions as indicated. For delivery and epidural anesthesia, 30 to 40 international unit per kg will be the dose as a single infusion, and the level should be more than 50 international unit per deciliter. For the frequent other bleeding like gastrointestinal hematorosis, 20 to 40 units per kg, twice to thrice weekly should be the frequency of infusions. And this is the ideal monitoring way during surgery. For a major surgery, the target plasma 1 milligram Rickhoff along with factor 8 should be monitored to maintain 100 to 50 to 100 international unit, and it should be maintained to 5 to 10 days of surgery. And for the minor surgery, it should be more than 30 international unit per deciliter, and for the dental extraction and other invasive procedures, more than 30 for more than 12 hours. And this is the take-home message. If we ignore the heavy menstrual bleed, we will ignore a life-threatening bleeding disorder. So we should investigate, reveal the unidentified. Thank you.
Stop sharing. Yeah. So, thank you. I mean, the blood pressure of the treating team should have been quite high while managing this patient. I know how difficult it was, but I think, and one of the problems I face, I would like your opinion, all the three teams, is getting von Willebrand factor rich factor 8 nowadays, right? Because of recombinant and all these things. So, is there an adequate stock always of von Willebrand rich factor 8 available in your pharmacies?
If I can start,
Yeah.
Prantha sir,
Yeah.
no is the answer, and
Yeah.
it is a von Willebrand factor is very much reduced in the stock, and even for this patient's surgery, I think we had to get it. We had to wait a very long time for the surgery because we had to get our stocks filled up for even for facing an emergency, like what we faced. So in this, I mean, at least in our state, we are facing shortage for the. I mean, plasma is in general short, but and then that makes it even more difficult for. Is recombinant von Willebrand available anywhere in the country? No.
I don't know. I have never
No,
seen it.
it's not. They're not yet launched actually. I think in India, one
Mm.
Wendy is not yet launched.
Yeah.
Same situation in Maharashtra also. We had a lot of trouble in arranging a factor for one of our patients who just delivered yesterday, and she had a bleeding, and then we are not able to get VWF factor now. Actually, it's very difficult because some of them actually don't have any stock in India. One who has stock has very little stock. So most of the government tenders are also not asking for VWF, at least in Maharashtra.
Yeah,
So I think
same
it's,
here. So
yeah,
we do have stock usually, but like currently we are facing, probably it's because of the tender, new tender kicking in now and purchases happening. So there is a break in availability right now, and so that is an issue. And one more thing I would like to point out is that we cannot use other plasma derived factor VIII. So a lot of people think that you can, instead of this you can use the plasma derived factor VIII that comes, but that is usually high purity that is there, so that cannot be used. So it has to be intermediate purity factor VIII that is there, and that comes specifically for this purpose only.
I think the advocacy for von Willebrand deserves a lot more. But I think before these were excellent cases telling us the story. But from each team, I would like you to give us 2 points to carry back to the clinic for the audience there, because I can't see any more questions in the chat box. So we have dealt in detail how even carriers can bleed, how von Willebrand disease patients bleed, and Glanzmann thrombasthenia is another nightmare for us. So giving platelets, and then ultimately we might have to use recombinant factor 7 8 so because of resistance, because whatever you use as a protein, the body develops ultimately tolerance to it and antibodies. So there's one question in the chat box. Any one of you can volunteer. Is there any evolutionary advantage for hemophilia carriers, like in hemoglobinopathy carriers, which provide protection against malaria?
So
Yeah, anyone?
we were thinking that hemophilia protects against the thrombosis, but nowadays we are seeing the patients of hemophilia, which is like elderly patients presenting with myocardial infarction, and I am not aware of anything which is protection at present. They are getting a disability benefit. That is the only thing which is happening, but otherwise I am not aware of any such protection.
Yeah. And the story of thrombophilia is different because it was found that because of a huge loss of life through PPH, probably factor 5 Leiden mutation developed. But that is another story that Manucci has demonstrated it well. But yes, I mean, this is a problem and it remains a problem. And the greatest problem in our country is that we have not diagnosed most of them. They're roaming about, they might lose their lives. And even in males, if we suspect hemophilia, if we have read one page in our undergraduate curriculum, for females, it is more difficult. Okay, there's a question which I think it would be very difficult for us to answer, but anyone can take it. It says how to procure factors and make it available at our center. I don't know who has asked it and what kind of a center it is, but because you are in a government center, Neeta, you can give some idea, like Chandrakala also, as to how to procure factors.
So the earlier question was from Dr. Sudipto. So that's why I was asking him, is this also your question? That
Yeah.
evolutionary advantage, he had put it out and he was waiting for somebody to answer it.
Okay.
So yes, so this is from Dr. Manoj, how to procure factors and make it available. So I think it depends
Yeah.
on which state you are. Um, Hemophilia is under every state has its own different way of procuring factors for hemophilia care. Most of the treatment is from National Health Mission. Most of the states are covered for treatment under National Health Mission. So if you are in a government sector working in either a district hospital or a medical college or an institute, you could apply to your National Health Mission state chapter, state blood cell, and then they will see what are the numbers of patients there. Is there any nearby hemophilia treatment center? And if there is, at least in UP, they have made a treatment center so that patients don't have to travel more than 50 to 100 kilometers. So at every 50 to 100 kilometers, there will be a center which is giving offering treatment. So they do that mathematics, they look at it, and then they see the number of patients, and then they add a center in your area. If it is a deserving place where patients are there and patients will benefit, they'll generally add.
Right.
And then the
Chandra,
procurement is from them, sir.
yeah,
Procurement, they generally provide funds, either funds to the, as in the state purchases its factors and this provides the factors to you. You don't have to purchase it on your own. So it is dependent on, as in every state's tender also is little different, but generally it's purchased in bulk for the year and then distributed to the centers.
yeah. Any words of wisdom, Chandrakala, from Maharashtra regarding procurement?
It is the same actually what Anita has elaborated. It is NHM National Health Mission provides the factor, but now National Health Mission has told that the government medical colleges and tertiary care centers will not get the support. So that's why it's some of the issues. I think you should speak to each state has a different policies. Speak to your blood cell; they are the best support for it. Because however you get from your hospital, however patient pays, you cannot fulfill the treatment. Hemophilia is a very costly disease. I always tell patients. So it's always the government support which is important.
Yeah, it cannot be out of pocket. Yeah. So there is another question in the chat box. I think Nita can take it because she described desmopressin in detail. Risk of hyponatremia with desmopressin during major surgery where physiologically DDAVP is high. So I think you touched upon it.
Yeah, so
Probably.
we don't generally use only DDAVP as an option in major surgeries. It is usually used for dental extraction, minor procedures as a factor, without factor only DDAVP. So I think for a major surgery like an abdominal surgery, etc., you will definitely require some factor cover so that your DDAVP dose is not that high. And then secondly, of course, if you are using DDAVP, you need to monitor, and then you will periodically monitor at least 2 times in a day sodium levels and then act accordingly.
And for people who are thinking what to do, let me tell you that a point of care device for diagnosis of severe vulnerable is on its way. So hopefully it's basically lateral flow immunoassay based. It will be available in India and that will make our job a bit easier. But I think the most important instrument we have is between our eyes and that is our brain. So always think that this is not the run of the mill thing, something else is there. If you start thinking like that, maybe we'll be able to diagnose more and more cases and manage them well. So as a concluding remark from each team, maybe 1 minute. So again, starting with Nita, then Chandrakala, and then Neeraj. Over to you, Nita.
uh, uh, going listening to at length with the presentation, I had this idea in mind that uh, the pictorial bleeding assessment chart that should be taught at the school level to young adolescents so that they can identify whether they are heavy bleeders or not. That can help us detecting a lot of patients early.
Yeah. See, because I have seen when I ask a woman that, is it heavy? She says, how do I know? I'm not comparing it with others. And that's a genuine concern. They say, I don't know. My mother told me, no, no, this is fine. So I entirely agree with you. It's a bit of a taboo, but to understand what is normal and what is not, I think this kind of awareness should be there. Thank you, Shridipta, for that point. So now to Chandrakala's team, any suggestion?
Uh, from our side, the suggestion would be all the hemophilia carriers should be they should be look for their baseline factor levels, and if they are going for any surgery or childbirth or any they are having trauma, the factor correction should be given appropriately so that we can prevent major bleeding manifestations in those patients.
Yeah. So the concept of carrier plus, right? So
Yes, sir.
carrier plus, then they become a patient. Yeah. Thank you for that message. Now over to Neeraj, Lindsay, and Rama. Your last comment.
Lindsay, do you want to have a go at that?
Yeah,
Um, Menorrhagia, of course, it is not normal. So keep our eyes open and do investigate. Uh,
yeah,
Something will be there.
yeah. And maybe we need to sensitize the gynecologists. I think that is one way we can do it. That not everything is dysfunctional uterine bleeding, and we should not waste time. It's
So
better.
there's
Yeah.
also there's also like I mean, I think you must have talked about it. I briefly lost connection, but then there is a lot of cultural taboo regarding talking about menstruation and heavy menstrual bleed, and many a time it is considered as okay in the family to
Hmm.
lose more blood because it is bad blood. Let it go.
Yeah.
So it we should start like we should start at very early stage the sensitization, like when they are when you are in a school or etc. But the sensitization of parents is also, I think, equally important. Sensitization of larger society is very important because this probably has to go both the bottoms up and top down also. Both approaches need to be followed here, and then only we will get a larger number of women who actually bleed excessively. Once you pick up the women who bleed excessively, then it will be an easier task for us to find out who among them have thyroid problem, who among them have dysfunctional breathing, or who among them have von Willebrand disease.
Yeah. Yeah.
One more
Thank
thing,
you.
doctor, actually, we have to mention is using a hormonal therapy is very important in these patients. So, patients will have menorrhagia, and along with menorrhagia, the hemorrhagic ovarian cyst is also one of the problem we face, and it leads to ovarian fibrosis and infertility. So it's educating regarding the hormonal therapy from the beginning. They think it's like a birth control pills. How I giving to my child actually who is a teenager. So educating the parents regarding this is not a birth control pills. It is to prevent the menorrhagia and treatment of menorrhagia, and adherence to the hormonal therapy is very very important in the further fertility of this bleeding disorder patients. So
Yeah.
that also has to be
So I
increased.
think next time we have a discussion, we'll also have gynecologists with us. So it's a cross talk, and we'll enjoy that. Let me thank all of you once again. I think we have been able to at least sensitize. There was a one question in the chat box regarding insurance of Hemlibra in the UK. We can't talk about UK, but I know in India, 2 or 3 patients of mine are getting insurance coverage for Hemlibra. That's a separate issue. It has no role in such patients where we discussed. So, thank you once again. And on top of it, I should tell you that there are very few people who are working in this arena. And if we have to bring down maternal mortality rate, if we have to bring down postpartum hemorrhage, this kind of awareness and knowledge is essential. Thank you once again, and hope to have a face to face meeting in future. Thank you. Over to the organizers.
Thank you so much, everyone, for a wonderful case study. As we know that we lack in the healthcare knowledge, but having such kind of case discussion in our country like India will be very much helpful to all the doctors, all the PG students who are practicing on their real experience too. And thanks all the everyone for your precious time and sharing your knowledge on our platform, and all the expert and all the presenter too. And I would like to also thanks to Dr. Prantar Chakravarti sir for moderating this wonderful session. I hope it will create an impactful in all the audience into the all audience. And we would like to see you in future also with different topic. Till then, take care of yourself. It was a wonderful discussion from your end. Thank you.
Thank you. And recording would be available also. So we'll
Yes, sir.
share
It
you the
will be
link,
shared.
which can be shared with other doctors. Thank you once again. Bye.
Thank you.